Hello everyone, let's talk about disseminated intravascular coagulation or DIC in short. It is an acquired systemic thrombohemorrhagic disorder. So thrombosis and hemorrhage both happen simultaneously. It has three key features which we will remember by T, P and F. So first there is excessive thrombin generation which causes fibrin deposition and microvascular thrombi. Then consumption of clotting factors and platelets lead to bleeding tendency. Lastly, there is secondary fibrinolysis which produces fibrin degradation products that worsens the bleeding. Because clotting factors are consumed, DIC is often called as a consumptive coagulopathy. Now, what are the causes? Let's think in groups. So first being obstetric complications like abruptio placentae, retained dead fetus, etc. Then infections, especially gram-negative ones. Then there is malignancy, trauma or massive tissue injury, and miscellaneous causes like transfusion reactions, snake bite, etc. Let's go to pathogenesis part step by step. First, we'll discuss the trigger. So there are two triggers, namely tissue factor and endothelial injury. So let's discuss the tissue factor part. So when tissue factor is released, it combines with factor 7, which activates factor 10 and 9. This leads to thrombin generation. Now, thrombin converts fibrinogen into fibrin, thus activating factor 9, 8 and 5. All this leads to fibrin cross-linking, inhibition of fibrinolysis and activation of platelets. This forms a stable clot at the site where tissue factor was released. And when this thrombin is swept away and carried by the blood vessel somewhere else, that binds to thrombomodulin receptor expressed by the endothelial cells. This activates complement and inhibits factor 5 and 8. This is the tissue factor part. Now, at the site of endothelial injury, TNF or tumor necrosis factor is released, which increases the expression of tissue factor and decreases the expression of thrombomodulin, thus leading to coagulation. This increases the adhesion on endothelium of leukocytes, which then releases reactive oxygen species and proteases. Secondly, there is antigen antibody complement formation like in SLE, which activates complement pathway. Then there is temperature mediated endothelial injury, and then by microorganisms by the release of endotoxins which inhibits thrombomodulin. Because of all this, then occurs widespread coagulation activation. Excessive thrombin is generated, leading to fibrin deposition throughout the microvasculature. This fragments the red cells, producing schistocytes, producing a microangiopathic hemolytic picture. Then, since the platelets and clotting factors are consumed, the reserves are exhausted. So, the clotting times are prolonged and thrombocytopenia sets in. Secondary fibrinolysis shows the plasmin breaks down the fibrin, producing fibrin degradation products, especially D-dimer. These FDPs further inhibit hemostasis, worsening the bleeding. So in summary, DIC is a vicious cycle of clotting and bleeding happening together. Non-morphology, we'll see microthrombi in brain, lungs, heart, kidneys, adrenals and pituitary. In the kidney, we can see microthrombi with cortical necrosis. In meningococcal sepsis, the adrenals undergo bilateral hemorrhagic necrosis, which is classically called Waterhouse-Friderichsen syndrome. And on blood smear, fragmented red cells or schistocytes indicate microangiopathic hemolytic anemia. Clinically, DIC has a dual presentation, thrombosis and bleeding. Under thrombosis, patients may develop organ ischemia and failure, like renal failure, neurologic deficits, or respiratory distress. Under hemorrhage, people show petechiae, ecchymosis, hematuria, GI bleeding, epistaxis, or oozing from wounds. Now remember that in acute DIC, bleeding dominates, and in chronic one, thrombosis dominates. The characteristic lab findings that we'll see are thrombocytopenia, prolonged PT and aPTT, elevated levels of FDP, especially D-dimer. So remember these three. This is the classical picture of a DIC. Then fibrinogen will be low, and in peripheral smear we'll say schistocytes. So the diagnosis requires both clinical suspicion and laboratory confirmation. The classic triad is low platelets, prolonged PT, aPTT, and high D-dimer, as we discussed, and sometimes ISTH scoring system is used for standardization. Now, treatment of DIC always starts with treating the underlying cause, whether it's sepsis, an obstetric complication, or malignancy. Supportive therapy includes platelet transfusions, FFP, cryoprecipitate for patients with significant bleeding. In selected cases of chronic DIC with predominant thrombosis, heparin may be used cautiously. The prognosis is highly variable. In some cases, if the trigger is removed, DIC may resolve spontaneously. May resolve completely. But in severe situations like sepsis, obstetric catastrophes, or leukemias, it can rapidly progress to fatal multi-organ failure. So to summarize, DIC is an acquired systemic coagulopathy characterized by both thrombosis and bleeding, with typical lab findings and morphology. Always remember, it is secondary to an underlying cause, and treatment must focus on that primary trigger. This is a must-know topic for exams and clinical practice. I hope it helps. Thank you.